All right, we are going to get going. So thank you all for coming here. Good afternoon. For those I don't know, my name is Sandro Galea. I have the privilege of serving as Dean of the School of Public Health at Boston University. And on behalf of the school, I am very pleased to welcome you to this is our first, hopefully annual, Think, Teach, Do Showcase. I'm particularly happy to do so in this beautiful new building, the Rajan Kilachan Center for Integrated Life Sciences and Engineering. So just a bit of framing. So over 2,000 years ago, as all talks should start, Aristotle suggested that humans engage in three basic activities: theoria, poiesis, and praxis, essentially thinking, making, and doing. At our School of Public Health, our philosophy echoes this insight in our core purpose: think, teach, do for the health of all. We think by generating knowledge, we teach by transferring the knowledge to the next generation, and we do by translating that knowledge to key stakeholders and the general public. We see this as central to our goal of creating healthy populations, and also our goal to bring Aristotle back to life again. So today is really meant to show how we work to embody this core ethos. The idea today is a rapid-fire event organized into categories of think, teach, and do, respectively. Our presenters include faculty, students, and staff. And this is going to be one of those events where everybody's going to be very, very brief to give you a true highlight of the work that we do at the school. Before we move on to the program, I would just like to thank the people who made this happen today. First of all, this event would not have been possible without the creative energy of Dr. Beverly Brown, Director of Corporate Relations at the school, and Jacoba van Houten, Assistant Dean of Development and Alumni Relations at the School of Public Health. Second, the Dean's Office and our communications team, who as always do a terrific job of coordinating this event, and its communications led respectively by Catherine Etman and Cara Peterson. And third, today we're showcasing work that represents our core Think, Teach, Do purpose. But I particularly want to highlight that a lot of the work you're going to see is novel research that falls squarely in the think bucket. Much of the research being presented here today emerged from work supported by the faculty pilot program, which supports innovative work and aims to catalyze research. I would like to take a moment to thank Associate Dean Mike McLean and the entire faculty and research and faculty advancement team who are instrumental in shepherding this program and truly taking the school's research achievements to a new level of excellence. Thank you all. Now, we have a full program, so my goal actually is to say as little as possible other than to provide the name and affiliation of each speaker. I would like to mention once again, though, how great it is to have you all here. Our first presentations fall under the Think umbrella, and I'm now going to turn the floor over to our first speaker, Ziming Zhuan, Associate Professor in our Community Health Sciences Department. Professor Zhuan, where is Ziming? There you are. Do you have the next slide? You're okay? That's it. There you go.
Thank you, Sandro. I'm Ziming. I'm Associate Professor from the Department of Community Health Sciences. I'm an Associate Epidemiologist, and I'm interested in social determinant of health. And particularly, I feel very grateful for your support to study, to collect data from state anti-bullying law and how that would impact youth suicidal behavior. Suicide is a major public health problem. It contributes 2% of global burden of disease. Every day, it affects millions. It affects millions Americans in the U.S., and annually it causes 44,000 deaths, which is the 10th leading cause of death in the United States. And the burden of suicide fell disproportionately among youth. It's the second leading cause of death among age between 15 to 24. And bullying and cyberbullying are the major risk factor for teen suicide. So with your support, I have gathered data across a span of 17 years from 1999 to 2015 on a variety of 16 components of anti-bullying law. And during this time, many states are actually, the state lawmakers are very eager and doing a lot of work to make anti-bullying law available to schools and school districts, beginning from Georgia in 1999 to the last state, Montana. So now 50 states, including DC, have anti-bullying law in place. And if you look at the trend on the right-hand side table with respect to each of those 16 components, the results are very encouraging. Those are the number of states, and it's trending upward. So now the thing question, do states with the anti-bullying policy, they are associated with lower rates of suicidal behavior among youth? So that is the key questions I hope that we can answer. So I was able to link the anti-bullying law with CDC's Youth Risk Behavior Survey from from 1999 to 2015, 16 years of data across about 900,000 high school students. And comparing the states with the law versus without the law, we are seeing a lower rates with the law in place. And we also get into odds ratio, so for some of the alumni in the audience, that will remind you some of the days that you are still learning statistics. The odds ratio is less than 1. That means for kids in states with the law, they're associated with lower risk of suicidal behavior with respect to suicidal ideation and also suicide attempt. So this is the first study that provides a population-level evidence that states with anti-bullying policies, they are effective in reducing suicidal behavior among youth. So I feel, again, very grateful because in an age where policy are made in the moment of heat and not necessarily the effective policies, but in terms of anti-bullying policies, they're effective based on this evidence. So I feel very grateful to be part of it, and thank you very much for your support. And I would try to get this into publication, and hopefully that will inform policy making in the national level. Thank you.
Thank you, Ziming. Next up is Wendy Hager-Bernays, clinical professor in our Department of Environmental Health. Wendy.
Thank you. Down is forward. Okay. Okay. Down is forward. Oop. To quote the noted scholarly source, Finding Nemo, fish are friends, but fish are food. On this slide, you see these little fish. They're called mummichug. And these fish live in clean waters and also heavily polluted waters. And in waters that we study, which is the New Bedford Superfund site in the southeastern Massachusetts. These little fish are low on the food chain. That means that bigger fish eat them and whatever in them, and then humans eat those fish. But interestingly, these fish serve as great models to study the health of the environment. But they also can be used as models to describe physiological outcomes similar to many of those seen in humans. When we bathe the mummichug embryos in environmental chemicals, tin or PCBs, we observe these birth defects located on the lower right. We see, if you can look at an embryo and see this, we see effects on their bone and on their metabolism. We're really interested in knowing the molecular events that give rise to these birth defects. And in order to do this, we actually need some very sophisticated molecular tools that are quite expensive. But with the support of this SPH pilot funding, we're able to use next generation RNA sequencing to investigate the expression of genes turned on or off in the treated embryos. The leftmost panel reminds us that genes are turned on, allowing proteins to be made. The timing and type of proteins made are critical to the normal development of all organisms. And the right side shows a heat map that we will be generating that will allow us to see exactly which genes are turned on and turned off in response to those chemicals. This is important because these chemicals are still in commerce globally, and humans are exposed to them. These data can support environmental protection of the fish and get us closer to understanding effects of these chemicals in humans. Human health and well-being are intricately linked to the state of the environment. This diagram illustrates our working model, showing the linkages between risks to the health of the fish and risks to the health of people consuming them. Thus, healthy fish, healthy people. I thank SPH for the pilot funds to do this molecular work, but also to the BU Superfund Research Program grant funded by the National Institute of Environmental Health Sciences, my colleagues Jennifer Schlesinger and Mark Hahn, and doctoral student Kate Crawford. Thank you.
Thank you, Wendy. Angela Bazzi is next. Angela is assistant professor in our Department of Community Health Sciences. Angela.
Hold on.
Right. Let's do Emily next. What's that?
Okay, sounds good.
Sorry about that. Emily, where's Emily? There you are. Emily Rothman's next. We have a technical glitch. It's probably my fault. I apologize. Emily Rothman, Associate Professor in Community Health Sciences. Emily, over to you.
Well, thank you very much. And you're actually getting 3 for the price of 1. I'm going to be co-presenting with my collaborators on my project. So we would like to thank the BU School of Public Health for the pilot funds in order to start this study, Alcohol Use Trajectories of Transgender Patients Receiving Hormone Therapy. We have started with data collection, and I will tell you a little bit about what it is that we're doing. So first of all, transgender people have a 3-fold increase of all-cause mortality as compared to non-transgender people. So an estimated 0.6% of the U.S. adults, which nets out to 1.4 million people, identify as transgender, which is probably an underestimate. And this population faces a tremendous health burden, and particularly if you look at suicide, there's a 19-fold increased risk of death by suicide. There are a number of other health problems that are sort of excess risks in this population. So we decided that we wanted to try to tackle understanding at least one small part of this problem. And what I did is got together with my co-PI, who is the medical director of the Center for Transgender Medicine at Boston University. And we are recruiting from his patient population 20 patients who are just starting hormone therapy. And when they start hormone therapy, we're doing some retrospective data collection with them in order to understand what their alcohol use patterns were prior to starting hormone therapy. We also collect information about what they call minority stress. So that's our model. If you look at it, internalized transphobia, gender-related discrimination. We're also collecting information about social support. We follow people forward in this particular study for 3 months, and we're going to then assess after they've been on hormone therapy for 3 months, have drinking patterns changed, the social support changed, depression, and frequency of marijuana use as well. So it's primarily descriptive, but because nobody has established what does alcohol use increase, does it decrease, and there's reasons why it could go either way, we think this will be important knowledge. So, Josh, if you want to talk for a minute about the Center for Transgender Medicine.
Yeah, I'm going to talk for, it sounds like 15 seconds. We are uniquely positioned to do this nationally, just so that you're aware, some people are not aware. Boston University is a national leader in terms of developing education for medical providers at the university, and with our Center for Transgender Medicine and Surgery in actually demonstrating how this care ought to be delivered to the community, and not with a very, very mental health focus that has been so in the past. And therefore, we're uniquely positioned to do all manner of studies. The gaps in the community are just ginormous, and every single one of these pieces are pieces that we need to be studying, learning about. Us as clinicians are, of course, super enthused because we need to learn how it is that we are, what differences we're actually going to be making with our interventions.
Our time is up, but I just wanted to briefly also acknowledge that our research assistant on our project, Sarah Reed, is here. And if people would like to talk to Sarah more about the project afterwards, then please approach her. Thank you.
Thank you. So sorry about my order confusion. Now we really have Angela Bazzi. Angela.
All right, so with advances in HIV treatment, people with HIV are living longer, healthier lives, and oftentimes forming relationships with people who don't have HIV. So we refer to these couples as serodiscordant, or sometimes we say magnetic couples, and these are couples in which one partner has HIV and the other one does not. As many of these partnerships are very long in duration, people are interested in having children, but natural conception still carries some small, although real risk in some of these relationships. So pre-exposure prophylaxis is antiretroviral medication that can be used for preventing HIV in HIV uninfected persons. And we're interested in exploring the use of this medication for safer conception among couples in the United States. So with SPH pilot funding, we were able to interview couples who are actually already using this technology or approach to learn about their experiences and hear their suggestions for scaling it up, because it's not used very widely yet. So we heard that couples experience a lot of stigma surrounding HIV and also their status as a serodiscordant couple. They talked about feeling disapproved of and, as a result, desiring to feel more normal and recognized as normal. And having a family was very much a part of that. As one woman told us, we're really just looking forward to having babies and like a complete family. Existing fertility treatments were viewed as unnatural, time-consuming, and very difficult. One woman told us, we want to have a family, we just don't want to have to go through all of these processes. And it's scary, and it's so much to go through. So PrEP was viewed as a tool for enabling natural conception that also enhanced the quality of people's relationships, as well as intimacy within their relationships. And so they said things like, I feel better knowing that we're protecting each other. It helps our sex life. And it instilled in some of the male partners a sense of pride and appreciation within couples. But we also heard suggestions for increasing awareness of this strategy. And this alluded back to some of the stigma, as well as some of the lack of awareness among providers and patients as well. So we heard suggestions about linking couples who are using PrEP for safer conception together so that they could learn from each other. We also heard about ways to increase awareness of PrEP for conception as a strategy that would not only help couples with conception, but also could eventually combat some of the stigma that they experience. So I'll end with this quote. I'm surprised nobody knows about Truvada. That's right now a brand name for PrEP. Why not tell everybody? Because that solves a lot of isolation, a lot of problems. If we can advertise for cancer, for diabetes, then we need to put Truvada out there. Don't not like or be around or love someone just because of HIV. There's preventatives. I don't see Truvada in the media, but it should be, like everything else. And so we're using this to think further about plans for improving the delivery of PrEP, improving the patient experience with PrEP for safer conception, and I'm moving forward with thinking about this for a variety of populations with funding that this pilot award helped me obtain. Thank you.
Thank you, Angela. And very good. Next up, Karen Jacobson, assistant professor in the School of Medicine. Karen.
So we received a pilot award, myself and Helen Jenkins, who's in the Department of Biostatistics at the School of Public Health, to develop a method of how to track individuals through time to find TB transmission hotspots in South Africa. So why TB? It's the leading infectious disease killer globally with 4,000 deaths daily. And we are actually particularly focusing on drug-resistant tuberculosis because it's a form of TB that's both harder to detect and harder to treat. So people are often delayed in terms of getting onto effective treatment, and during that window of time have a continued transmission to others. Transmission is easy. All the person has to do is cough, and if someone breathes in that air, the bug is transmitted to others. Not surprisingly, though, tuberculosis is not homogeneously distributed throughout the world. We have, on a country level, a lot of heterogeneity. You have countries like South Africa, China, India with very high burden compared to Western Europe and the United States. But even within countries, there's a lot of heterogeneity, and there's populations that are particularly affected that we're not good at detecting at that sort of granular level. We're focusing on South Africa, which has one of the highest TB rates globally. There are 834 cases per 100,000 population. That's in comparison to 6 cases per 100,000 population here in Boston. And that equals about 450,000 cases a year. And although a small percentage of those are drug resistant, only 4%, this takes up more than 50% of the budget. So focusing in on that part is particularly important. But really what we're doing with this funding that we received from you is trying to say, how can we take routinely collected data, test data that's collected at the National Health Laboratory Systems and transform it into a surveillance tool so that resources can really be well directed. So when we talk about tracking TB cases through time, what are we trying to detect? We're trying to detect which populations are at higher risk for disease, where did an outbreak originate from, and where can we expect future outbreaks to arise. And we want to then use that information to figure out where to direct additional resources or use resources that are already available, where do we need to do further research, and why, potentially even getting to causality, why is this happening in some of these populations and maybe not the population just down the road. So our data is actually built off of 2 K awards that Helen and I both received, where we were looking in a much more transsectional way and trying to pick out how do you take, like I said, a specimen data bank, so everyone who's a TB suspect gets laboratory tests to detect their TB and their drug-resistant TB, and how do we build off of that laboratory-based data set to really start to track people and find where they are. And so a lot of our work on an earlier data set had been really coming up with where do you find them? And I think looking at these images, these are heat maps that we created based on proportions of drug-resistant TB for TB in clinics across the Western Cape province. I think we would all agree that this is not homogeneously spread. If anything, it's remarkable to see that although 4% of the cases have drug resistance, nowhere is there actually 4%. You often see areas as high as 20% in some communities and some areas where you don't need the resources because there doesn't seem to be drug-resistant TB circulating. So what we want to do with this pilot award now is to start to really think about if we can actually look and say, are people tracked through time getting onto therapy and staying on therapy? Can we model whether those communities where more people stay on therapy have some of the decrease in disease over time versus those where individuals are lost more frequently, and maybe that needs to be where resources are put. So we very much appreciate the funding that we received. We also, like I said, received funding from the NIH, NIAID, and the Fogarty Institute, and are excited to take this forward and have an R21 that we're writing to further build on the pilot data that we're getting from you. So thank you.
Thank you, Karen. One of the real joys of working in a school of public health is just the absolute breadth of scholarship that happens in the school. And when you see it all, like, you know, as a dean of the school, I have the privilege of knowing a lot of this, but when you see it like this, it's like, this is incredible. Like, we go from like fish to same-sex couples. It's amazing. It's really a delight to be in this kind of intellectual environment. Next up, Jessica Liebler, Assistant Professor of Environmental Health. Jessica. Oh, to rats. We're like really in zoonotic space today. Jessica.
Thank you. Thank you so much. It's a pleasure to be talking with you about and to hear all these exciting research projects today. My name is Jessica Liebler. I study wild animals, among other things, but rodents and other sorts of wild birds, and also cows and other sorts of domesticated animals. I specifically study from animals to people and then back to animals. With support from the pilot fund at the School of Public Health, I was grateful to receive pilot funding to look for Staph aureus in wild rodents in the city of Boston. And Staph aureus, we were interested to consider wild rodents as reservoirs of pathogens, of bacterial pathogens in urban areas. So we have known that rodents have carried pathogens of relevance to human health for centuries. And the question I was looking at here is whether or not rodents play a role in transmission of Staph aureus, which is primarily a human pathogen, but has been known to be carried by animals as well. And I was specifically interested in MRSA, which is methicillin-resistant Staph aureus, a particularly drug-resistant type of bacterial infection that affects humans and can cause many different sorts of complications, skin infections, sepsis, that is difficult to treat clinically. And as I said, wild rodents are well known to carry pathogens of concern. So the question is, could rodents in Boston play a role in transmission of MRSA, of this drug-resistant pathogen, in our city? And so we've collected about 80 rats to date. I'm partnering with the veterinary school at Tufts and the Boston Sanitation Services program. And we are collecting rats primarily from Back Bay, South Boston, and Chinatown. And we are dissecting them, taking them apart, and putting a lot of their organs into a repository. But we are looking for Staph aureus. We're also looking for a few genes that code for drug resistance across multiple species of bacteria. Thank you. Specifically the MEC-A and MEC-C genes, which can cause or allow a bacteria to develop drug resistance, different sorts of bacteria to develop drug resistance. We also, kind of in a fortuitous sort of way, had a colleague at Tufts who was interested in trying to see if he could recover influenza from the wild rodents. And he said, could I swab their paws to see if we could find flu? And we said, okay, and he did, lo and behold. So that's kind of taking this project in another direction, looking at urban rodents as a reservoir for influenza virus in the context of this city. So what's been so exciting about this pilot fund has been the ability to really take a very kind of novel and unusual hypothesis into the field, which is not something we would have been able to do without this sort of funding source. It's allowed me to jump into a lot of exciting new collaborations with veterinarians, with the city of Boston, has provided preliminary data for 2 grant proposals that are forthcoming in the next 6 months on related topics. And the next step is sort of really kind of looking at that correlation between human and rodent carriage of these pathogens in the city.
Thank you, Jessica. Next up is Daniel Brooks, Associate Professor of Epidemiology. Dan.
Great. Well, thank you. I'm really happy to have the opportunity to share the work that's been supported by the pilot program at the School of Public Health with you. We're focusing here on tobacco, and I have to say that tobacco, we've known for so long that tobacco causes all sorts of problems and is really bad for you, that in some ways it's treated as old news. And I think that some people, it's perhaps a bit underappreciated that, in fact, smoking is still the #1 preventable cause of death, according to CDC definition, with 480,000 deaths per year related to tobacco. These are preventable deaths. That is 1 out of every 5 deaths in the U.S. population among adults. But who actually smokes has really changed over time. So we know, in general, smoking has come down. But if you look at this graph, which is of smoking by gender, you see that back in the 1950s, men were much more likely to smoke than women. But at this point, there's almost no difference. So the gender difference has almost completely disappeared. What that's been replaced by, however, is a socioeconomic difference. And so here we look at education. If you go back to the early years, again, you see this is exactly the opposite patterns. There were little difference in socioeconomic factors related to smoking prevalence, and now that difference has increased greatly. So the people who are smoking now are most likely the socioeconomically disadvantaged. We can dig into this a little bit more by looking at current data from 2015. If you look at the education data, we still see the same kind of trend here. I was able to add the people with the graduate degree in here. I thought it would be relevant for this audience. And you can see that if you have a graduate degree, 3% of people are smoking. Okay? Whereas if you haven't graduated from high school, you're up over 25%. We see the same thing for below the poverty line versus above the poverty line. But for today, I especially wanted to draw your attention to a population group, which is people in public housing. 34% of people in public housing are current smokers. While 34% of people are smoking, that means that there's also 2/3 of adults who are not smoking, and 600, which is over 1 million adults. There's also 600,000 children who live in public housing. So this is a lot of people who are potentially exposed to secondhand smoke and the negative consequences from secondhand smoke. So, and what you have in public housing is this perfect storm of a lot of smokers, which creates a lot of secondhand smoke. They live in apartment buildings that are old, which allows a lot of travel through the building to distribute the secondhand smoke. And the people who live there have a lot of comorbidities, asthma, heart disease, diabetes, and so forth, which makes people more susceptible to secondhand smoke. So all of these things come together to create a large risk from exposure to secondhand smoke. In order to protect residents in their properties, the Department of Housing and Urban Development passed a policy that mandates smoke-free policies across the whole country. So that's in almost 3,500 authorities across the country. People cannot smoke indoors as of August 2018. So that's a policy that's going to be in place, but we know from policies in general that success is not necessarily guaranteed. There's a lot of things that have to happen in order for this to be effective. So what can we do? Well, it turns out that there's already over 600 public housing authorities, including in Boston, that have already gone smoke-free. So maybe we can learn from them and what their experiences have been. So this is something that we set out to do with some with colleagues from HLPM department and from Harvard. We thought that the potential elements that really would define success in a policy, this was our hypothesis, would be to involve residents, to engage them, to train staff appropriately, to get assistance from the public health agencies and organizations that are available, to have a balanced approach to enforcement, not too heavy, but not too light, and to, importantly, provide assistance in cessation, good assistance in cessation for people who, in fact, are going to find it harder to maintain their addiction. So what did the pilot funding allow us to do? Well, we already had other funding for part of this study. That was through Robert Wood Johnson Foundation and the American Cancer Society. That funding allowed us to do an online survey of 160 directors of public housing authorities around the country. 35 of those we were follow up with detailed interviews, and we were also able to review the written policies. What's missing, though, and what was missing in that, was actually seeing the conditions on the ground and actually talking to residents. And so that is what that's what funding from both SPH and CTSI allowed us to do. So these were allowed us to do these various site visits and to really learn in much more depth what was actually happening for people who are trying to implement this. The impact of this has been that we're now recognized at the federal level and in different organizations as experts in this area, and we've been able to provide and feed back to HUD and to other agencies as well this information that will help them in their implementation. And secondly, we have put in 2 funding proposals to really do work to increase the effectiveness of this rule in reducing health disparities. One was submitted yesterday to work in Boston Public Housing, and then we have a large grant that we put in, a PO1, that would be a collaboration with Harvard and Mass General, which is being reviewed next week. So fingers crossed, everybody. Okay, thank you very much.
Thank you, Dan. Next up is Professor David Scher, Professor of Environmental Health. Dave.
Okay, thanks, Dean Galea. Okay. Yeah, I'll use this. Let me start you off with a reality check. How are we doing saving cancer patients? Well, if you got a very aggressive inflammatory breast cancer around 1970 or so, about 50% of these people would die from cancer within about 3 or 4 years. And we haven't really improved that much in the decades since then. Oral cancer is another ugly cancer. Percent of the patients survive about 3 years. So I'd have to say that the answer to this question is a resounding meh. We haven't done that great. How can we do better? Well, we can take some hints from the environment, and more specifically, the chemicals that are present in it that we put into the environment. Now, many of these chemicals are carcinogenic and immunosuppressive, and they are so because they interact with a protein in these cells called the aryl hydrocarbon receptor, or the AHR. What we've found over the last dozen years or so is that these environmental chemicals that we're all inhaling when we step outside here today activate the AHR and then do what we scientifically refer to as bad stuff in cells, and that includes cancer invasion, metastasis, and immunosuppression. So with the help of the pilot funding that we got from SPH, for which we're hugely grateful, we were able to identify and characterize some AHR inhibitors with the idea of either preventing occurrence of these cancers or treating these cancers and ameliorating the disease. So I'll show you a little bit about how we're doing with some of these inhibitors. This is a really aggressive triple-negative breast cancer, a human cancer growing in a very invasive, kind of an ugly format. If you treat these tumors with our AHR inhibitors, everything disappears. All right, it's back. Thank you to the NSA for doing that. Okay, so they grow as these real nice globule spheres. If you were even a mediocre surgeon, you can extract these things. These tumors also form metastases in mice. So each one of these spots is a metastasis caused by this human cancer. So there's quite a lot of them. You can see even a few painful-looking bone marrow metastases. But if you treat the mice with these AHR inhibitors, this is what it looks like. So that's a great step forward. But actually, tumor cells are extremely resourceful, and they have a number of redundant mechanisms they can use to bypass the inhibition of even a single targeting pathway like the one I just showed you here. So in order to really achieve some kind of a cure, you really need to have some kind of biologic system that can respond to these tumors as they are changing. And you're going to give me the answer to what that kind of biologic system is, you and the memory of Karnak the Magnificent. And if you don't remember who this guy is, look it up on your telephone. So the way this works is it's audience participation. Everybody raise your hand, please. Thank you very much. The answer to the question that's about to show up is everybody. You can put it down now. And I have the answer here in this envelope that's been hermetically sealed since noon today. And the question to your answer is, who here has cancer? And the answer is everybody here has had cancer at one time or another. And the reason you don't know it is because the immune system has fought it off. Now, remember I told you that some of these chemicals are immunosuppressive, and they are so because they activate the AHR in the immune system. So we asked the question, what happens if you take the AHR away just from the immune system? Will it now rise up and fight these cancers? And here's what happens in a nonpartisan cancer called the glioblastoma, or brain cancer. Here's how the cancer grows in the brains of mice over about 26 days. But if you knock the AHR out only in the immune system, that happens. The immune system really has risen up and has killed the cancer. So in a couple of years, we think, in the short term, what we're going to be able to do with additional funding, perhaps through SPH, is to take these drugs into the clinic and really do some good. That's great in the short term, but in the long term, we want to do something else. Look at these numbers about how many people in the United States die every year from cancer. So it's almost 500,000 deaths. With the information that we have and that we think we can develop over the next couple of years, we think we might be able to inhibit or prevent, let's say, 10% of these cancers. 10% is 60,000 people. That's 1.5 Fenway Parks every year that you can save these people. And we're hoping that in the long run, we'll be able to develop this even further and make it look more like this, which is basically what Fenway's going to look like during the rest of the playoffs. Thanks very much.
Thank you, Dave. Staying with environmental health, Professor Madeline Scammell, Associate Professor of Environmental Health. Madeline.
Wow, Dr. Scher is a tough act to follow. I'm so honored to be among everyone here, and thank you for being here. This is not my first slide. Hold on. All right, I'm going to try this again. I'll just use the arrows on this. Yeah. Oh, so my first slide is a little different than it was, which had all of my co-investigators included on the first slide. So I wanted to start by acknowledging them, including Dan Brooks and Mike McLean and Omid Ameli, who I've been working with on this project, as well as the funders from the JPB Foundation, the Environmental Health Fellowship, and the Robert Meenan Innovation in Big Data Award, which if you know me, you know this is a big learning curve. So the topic of my research is chronic kidney disease, which is very common. It's a leading cause of death in the global burden of disease, but 1 in 7 people in the United States have chronic kidney disease. We have fairly good prevalence data, not very good incidence data, which is essential for understanding causes of chronic kidney disease, which are widely believed to be primarily caused by diabetes and hypertension, with a few autoimmune diseases and cancers and other conditions added to that. Chronic kidney disease of non-traditional etiology are the diseases we don't know the causes of, which are especially prevalent in different parts of the world. This graph shows mortality rates, death rates per 100,000 population in a select number of countries. What I hope you see here are on the left, the male rates over time are steadily increasing in the countries of Nicaragua in orange and El Salvador in the hot pink. This is a disease affecting primarily young, working-age men with no pre-existing diabetes, hypertension, or other known risk factors. And if you're not familiar with reading graphs, this photo of a coffin builder in Nicaragua may bring it home to you that these deaths are felt widely throughout the entire community and nation, for that matter, in both Nicaragua and El Salvador. So we, those of us who have been studying this epidemic in Central America for some time, have been suspecting that this disease, CKD of non-traditional etiology, also occurs here in the US. But how best to explore that question, which we were more inspired to do last year when this case report was published in the American Journal of Emergency Medicine. These clinicians identified a case of what they called Mesoamerican nephropathy, also CKD-NT. And when the person presented in the emergency department, they were treated, my time is up, they were treated for heart failure. And it wasn't heart failure, it was chronic kidney disease, but they didn't anticipate it. So my work is to explore an incredible data set of 140 million lives longitudinally, examining incidence rates and prevalence rates for chronic kidney disease to tease out what is this chronic kidney disease of non-traditional etiology we're seeing, and what are the rates here in the US? So with Optum Labs data set of healthcare claims and electronic medical records, we're able to answer that question, but you'll have to wait until the next Think, Do, and Teach to learn the answer. Thank you.
The award for the best cliffhanger so far goes to Professor Scammell. I like that. Come back next time and you'll find out the answer. Thank you, Madeline. Next up, Jennifer Ryder, Assistant Professor in Epidemiology. Jennifer.
So thank you for the invitation. I am a cancer epidemiologist with a long-standing interest in infections and cancer. And recently, I've become interested in cancer outcomes among people with HIV. Okay. So we know, as we've heard already today, that effective HIV therapy has dramatically increased the life expectancy of people living with an HIV infection. So as at one time, AIDS-defining cancers, which include cervical cancer and non-Hodgkin's lymphoma, were very important sources of both morbidity and mortality among people with HIV. Those are now declining. And now we're seeing increases in the incidence of a variety of chronic diseases, including cardiovascular diseases and other cancers. We know that HIV-infected persons have much higher risks of several different cancer types. But prostate cancer is an important exception. So we quite consistently see 30 to 50% reductions in prostate cancer risk in HIV-infected men compared to the general population. And perhaps for this reason, prostate cancer has received relatively little attention in the context of HIV. But I think that this statistic conceals some important trends. So if we look at prostate cancer incidence in the US over time, you can see that rates have been stable or declining somewhat over the last couple of decades. But the picture in HIV-positive men is quite different. There we see this dramatic increase in prostate cancer incidence over time. On average, we're seeing about a 10% increase in prostate cancer incidence per year. And this is actually the tumor type that's increasing most in HIV-infected populations. So this doesn't mean that HIV is a cause of prostate cancer. This just reflects the changing demographics of HIV-infected populations. But an important issue underlying this in the US is that men, African-American men, are both more likely to be diagnosed with HIV and more likely to receive a diagnosis of aggressive prostate cancer. So disparities here could actually be exacerbated. When we look at this globally, the areas of the world that have the highest rates of prostate cancer mortality are also those that have been hit hardest by the HIV epidemic. So it's very important to consider whether there could be more effective early detection programs or treatment programs that are specifically tailored to HIV-infected men. Pilot funding has allowed me to, first of all, engage a multidisciplinary team of investigators who are also really interested in this question, to identify existing data sources. So we'll be collaborating with the multi-center AIDS cohort study, which has enrolled HIV-infected and uninfected men across several cities in the US, and to generate some preliminary data. So we are specifically interested in the tumor biology of in prostate tumors from HIV-infected and uninfected men. And here we were able to generate some preliminary data showing that the HIV tumors do appear to be, HIV-positive tumors do appear to be more aggressive. So I'm very grateful to the pilot funds for allowing me to do some of the thinking to lay the groundwork of a larger study. So thank you very much.
Thank you, Jennifer. Next up is Professor Paola Sebastiani in the Department of Biostatistics. Paola.
I want to switch gear here, and rather than talking about diseases, we are talking about how to avoid diseases. And I've been working with the New England Centenarian Study for more than 10 years. And one of the major contributions we have made in the last 10 years in this field of extreme longevity is, to provide evidence that centenarians, many centenarians, manage to compress morbidity to the very end of their lives. So these are individuals who live, the median age of people in the study is around 104 years. And these are individuals who maximize their lifespan, but also optimize their health span. And they manage to do this really well. So they get sick at the very end of their life, and the time they spend with morbidity and disability is very, very short. So then the big question is how they do this. Our hypothesis is that genetics is a major contributor to this phenomenon. And this is in part based on the evidence that familial longevity cluster in families, and exceptional longevity cluster in families. So the picture in the slide here shows the lady in blue is the longest lived woman in the United States. She died at the age of 119. And in this picture, the lady in red is her daughter, who died at the age of 101. And these are just two members of a family enriched of very long-lived individuals. And Tom Pearls, who's my collaborator, he showed a few years ago that siblings of centenarians have a higher chance of reaching extreme ages, suggesting that there is a strong genetic component. But this study was based on a very small set of families. So our goal was to generate a large number of multi-generation pedigrees to extend this analysis and show strong evidence that genetics plays a major role in this phenomenon. So with the pilot funding, what we did was to curate a database that we have of multi-generation pedigrees. So when individuals are enrolled in the study, they provide some initial information about family members, and our task was to use resources like Ancestry.com, FamilySearch.org to complete the data as much as possible. And with the data, what we have done is to first show, without any doubt, with very strong statistical significance, that siblings of centenarians have a much higher probability compared to the general population to reach extreme longevity. We have developed a tool to actually use familial longevity to predict the chance of any individual to survive to a certain age. Feel free to use if you want to know your future. And we have established a framework, a conceptual framework, in which we really show that to study extreme longevity, one has to look at very extreme ages. This framework has been adopted by collaborations by consortia and has led to important findings. In particular, one second, we have shown, for example, that looking at long-lived individuals, we can start identifying genetic variants that are protective of disease. And we found one that reduces the risk of cardiovascular disease by 20%, which is a substantial effect. And thank you very much.
Thank you, Paula. Next up is Professor Martha Werler, our chair over Department of Epidemiology. Martha.
Thank you. I am a birth defects epidemiologist. I've studied birth defects and a variety of risk factors for birth defects over much of my research career. And one group of defects that I'm particularly interested in, or one type of exposure I'm particularly interested in, are medications. And so this project is to look at CNS active medications taken in pregnancy in relation to a range of birth outcomes. And I selected these particular medications because there is some question in the literature as to whether or not they are associated with adverse birth outcomes. They are increasing in use over time. For example, the bottom group, pain meds taken for acute chronic pain or for those unfortunate folks who become addicted. We know about the increase in opioid exposures, and we are seeing that in pregnant populations as well. We have a rise in antidepressant use. Seizures, thankfully, have not been increasing over time, but there's a great deal of debate about the right treatment options in pregnancy. So these medications are taken for these range of indications, but they're all clinically important. And particularly in pregnant women, it's important to figure out what the best treatment choice would be, not only to address the condition that's being treated, but also in consideration of the fetus, right? You're treating for two. And so then on the birth outcome side of things, there are two different malformations that we are exploring. One, neural tube defects. This is a very serious group of malformations that include an unformed brain or unfused cranium or spinal cord. Spinal column, and so they're either incompatible with life or can carry lifelong, very severe medical sequelae like mobility problems and bladder incontinence. Cardiovascular defects also very serious, usually requiring corrective surgery, sometimes in the newborn period, other times later in life when cardiovascular demand can become more intense. And then we have two markers of morbidity in the neonatal period, NICU admissions, and then infant admissions to hospital. And so these are the exposures and outcomes that we selected to study, as I mentioned, because there's some hints in the literature or they're increasing over time. But in order to study them, we need big data. So that's where my award comes into play. So this is just showing that when you have exposures that are relatively rare, like anti-epileptic medications, outcomes that are relatively rare, like neural tube defects, you need a lot of people to study. The previous studies that have looked at these research questions have suffered from small numbers, particularly when you're trying to compare whether one drug is superior to another. And so the big data that we are exploring is the Optum data. And I'm able to do this through a Meenan Award, which is a nice opportunity to be able to exploit the Optum data. And we just got permission to access those data via the sandbox yesterday. So we're just delving in, but we hope to be able to answer some of these pressing questions about the best treatment choices for pregnant women and their babies. Thanks.
Thank you, Marta. Next up is Rachel Bonowitz, Assistant Professor in Global Health. Rachel.
Thank you, Sandra, and thank you for the opportunity to talk today. I will be talking a little bit about HIV as well as pregnant women, so touching on a couple of topics we've already mentioned today. HIV remains a huge problem across the world with nearly 40 million people still infected globally. We've discussed that already. I'm a pediatrician by training, and what I care about, however, are the nearly million children every year who are born exposed to HIV. However, we have tools in our repository to help this, known as PMTCT. I don't know how to get the pointer to work, but PMTCT just means prevention of maternal to child transmission of HIV from mom to baby. All that means is simply putting moms on appropriate and easily available antiretroviral medications treatment for HIV. When moms get started on HIV medications at any point in their pregnancy, it decreases the risk of transmission to their infants from 40% to less than 2%. So this is a major public health success. Like, all right, awesome. This is fantastic. A little adjunct to PMTCT is also giving the infant who's been born to an HIV-positive mom 6 weeks of prophylaxis medication before they are tested for HIV at 6 weeks of life. All right, so this is a success story. Nothing else to talk about. However, not quite. We know that HIV-exposed babies have increased morbidity and mortality compared to unexposed babies. They've dodged the bullet of HIV infection, which is fantastic, but they are dying at higher rates from pneumonia and diarrhea across the years that we've been able to study this in observational studies. This is where the pilot grant comes in. I was fortunate to receive funding and take advantage of my colleagues in the Department of Global Health, Laura Sabin and Lisa Messersmith. They had a large trial funded by the NIH looking at how to improve moms themselves taking HIV medications in rural Uganda, kind of central rural Uganda. This is one of our study sites. This was a ripe opportunity to use these HIV-positive pregnant women who are initiating HIV medication to be able to study their infants and study these exposed infants and see if we can answer some of the questions as to why these infants may be sicker or dying more easily than unexposed unexposed infants in general. So this was a ripe opportunity to take a look at how babies were adherent to their daily nevirapine prophylaxis, as well as how adherent they were to getting their HIV test at 6 weeks. The pilot funds enabled me to go to Uganda to enroll the babies in the study, as well as to invest in new technology, though it looks like a rather generic pill bottle up there, which is able to measure the amount of medication that the moms are giving to their babies every day for their nevirapine prophylaxis. To my knowledge, this is the first time this has ever been done before, and we haven't published the results yet, but you get a teaser of it. The graph on your left-hand side illustrates the administration of the HIV medication to the infants who are born to the women in the study. In an ideal world, there would be 1 dot per 1 day given at the exact same time, so just a straight horizontal line across that graph, indicating that these moms are giving the medications as prescribed and hopefully preventing further transmission of HIV through breast milk to these babies. You can see this is not the worst example in the whole bunch, but this medication administration to this infant was all over the place through the about 8 weeks that the mom had this bottle. And we can see on this graph here, though I won't go into detail, only about 82% of all babies in the study actually got the nevirapine prophylaxis that they were supposed to get, and none of them got their HIV test on time. This doesn't answer the questions, which remains a research question of mine, as to why HIV-exposed babies do worse than unexposed babies, but it does generate some hypotheses for how we could be taking better care of these babies overall. I want to remind you that this is nearly 1 million children globally, worldwide, in the United States, who we are failing despite the success of PMTCT. So I just want to thank you for the pilot funds and the opportunity to present the work.
Thank you, Rachel. Next up is David Jones, Assistant Professor, Health Law, Policy and Management. David.
Thank you. So we'll start with a shameless plug. I'm very excited. In a couple of weeks, a book of mine is coming out in which I have asked the question, why have 34 states rejected the opportunity to build a state-based health insurance exchange as part of the Affordable Care Act? Even though the Republicans going into the ACA said they wanted state-based health insurance exchanges, the federal government promised to give lots of money and threatened to take over a state that didn't do it. So did about 200 interviews for this with policymakers in 23 states. And I would love to talk at the reception about the book with anybody. But one of the real frustrations I had coming out of this project is that the conversation around health reform in this country is so disproportionately focused on medical care and access to health insurance. So trying to think about how to reframe this conversation. My current project is retracing Robert Kennedy's steps in the Mississippi Delta. This year is the 50th anniversary of his iconic trip to the region. in which he was there really only for a day, but it sort of became this, this important event that has really energized a lot of activists in the 50 years since. So I'm going down now with, I went down 2 years ago with some pilot grant money from the School of Public Health to do some interviews, get a lay of the land, which I then used to get a Robert Wood Johnson grant, where they're funding me to write a book, try to understand the social determinants of health in the Mississippi Delta, why 50 years later is the Delta the least healthy place in the country. And one of the statistics that really blew my mind when I first started going down there was that an African-American baby in a rural county, Tallahatchie County, has worse birth outcomes than a baby in third world countries in Africa. So one of the issues I'm navigating, though, in this project, sort of like Robert Kennedy, right? He's a Bostonian living in New York, going to the South. I'm a New Yorker living in Boston, going to the South. You know, as a white man from an elite university, privileged background, PhD, the whole thing, how to respectfully tell this story. And so one of the things I'm doing with the grant, the pilot grant, and then the Robert Wood Johnson grant, is I am using photo voice, in which I give people cameras. I hold focus groups, give people cameras, and I ask them, you know, questions about their environment. Tell me where you live. Tell me where you go buy food. Tell me where you go get health care. Go out and take pictures. Come back next week, and we'll use those pictures as the basis of a conversation. And it's been wonderful. We've done about 3 groups so far, getting ready to launch 2 groups in the city of Greenville, Cleveland, and Clarksdale. Use that as a final thing to say, editor-in-chief of the Public Health Post, total non sequitur. Other than that, Public Health Post is an online publication that is housed here at the School of Public Health, which is focused on translating research into policy, right? So better informing policy, taking all this great work, all this great thinking that's happening here and trying to build a bridge for policymakers and journalists to better do what's happening. And so very excited about this is a screenshot from the article we ran March 27th. Since we launched a year ago, we have literally published an article every single workday. So we're very proud of that. And so thank you very much for the chance to be here.
Thank you, David. Next up is Keith McInnes, Research Associate Professor and also in Health Law Policy and Management. Keith.
Thanks. While I was sitting in the second row, I thought of another study, another pilot study we could do, which is the association of an occupational study looking at the association of neck injury and where you sit in a theater. It's kind of tough in that front row. So people may remember this article, 2011, from the New Yorker. A city in New Jersey was trying to figure out how they could improve on reducing healthcare costs, and they decided to focus on patients who were using a great deal of care, emergency room care, hospital care, and they called this the hotspotter approach. And basically that's what we're doing with our pilot funding, except we're doing a fairly light touch approach. We're using text messaging with 60 patients who are getting care at Boston Healthcare for the Homeless. And the idea is to send them text messages about appointment reminders and medication taking, and also to assess over time their mood and see if there are any associations between their ability to manage their chronic care and mood. One of the really most important aspects of this study is that we have a patient advisory panel that we've put together at Boston Healthcare for the Homeless, and they are crucial to helping us with everything from the content of our text messages to what kind of gift cards would be useful. So it's a really important part of this study. Very briefly, the pictures here show our concept, or our goal is that each of our patients will have a cell phone. If a patient has a phone, they use their own. If they don't have one, we give them a phone and show them, give them a brief training on its use. Our hope is that the messages they receive will lead them down that straight path towards getting their chronic care, getting to their appointments on time, and taking their medications. and avoiding the expensive care when their chronic condition spirals out of control. The grant has been very helpful in a number of ways. I think there's unique aspects in that the reviewers understand the Boston area, so they understand that Boston Healthcare for the Homeless is a premier clinical area and a premier research partner. They were very quick in terms of turnaround. We had an opportunity to join with the city of Boston, which was recruiting patients who were homeless. And in that way, we were able to kind of work with them and save time on some of the recruitment processes. They keep us posted on patients, and then we often recruit the patients they've already recruited. Thank you.
Thank you, Keith. Next up is Katie Berry, Research Fellow in Global Health. Katie.
Thank you, Dean Gloria. All right, got it. Thank you. Sometimes public health research doesn't involve creating something new. Instead, our work is often about recognizing untapped potential and retooling systems already in place. In this case, transforming routinely collected pharmaceutical distribution information into a research database that can be used to inform health policy. The Western Cape provincial government in South Africa established the Chronic Dispensing Unit to reduce staff workload and decongest the public health care facilities by distributing medications to patients with stable chronic conditions. The process is simple. Doctors see patients and write prescriptions that are sent to the CDU. There, the medications are packaged and shipped back to the health facilities where they can be picked up by patients. The CDU serves more than 200,000 patients and 200 facilities in the Western Cape province, and it distributes more than 1.5 million pharmaceutical items per month. This amounts to a total of more than 90 million prescriptions over the past 5 years. Funding from the BU-SPH Pilot Award allows our Boston team, led by Andrew Stokes, Sydney Rosen, and Richard Lang, to take this massive web of logistical information from the CDU and transform it into an accessible research database containing answers to important health policy questions. Development of this database builds the infrastructure for real-time monitoring of chronic conditions in South Africa. Our team, which includes Boston University researchers and collaborators from the Western Cape Provincial Government's Department of Health, the University of Western Cape, and the Health Economics and Epidemiology Research Office in South Africa, plans to use this information in this research database to investigate the patterns in adherence to medication and retention in care, to estimate the overlapping burden of chronic conditions like diabetes and HIV, and to create maps showing the distribution and trends in chronic disease across the province. However, these aims are just examples of how the CDU data can be tapped to inform health policy, monitor prescribing practices, and evaluate national guidelines. Our goal isn't just to pursue these aims, but to make the information collected by the CDU open and accessible to all, and to stimulate further research. The next great idea for utilizing this exciting CDU data could come from a research collaborator at a partner institution, from a politician in the Western Cape, or from a student in Boston, South Africa, or beyond. Thank you.
Thank you, Katie. Next up, Elizabeth Hatch, Professor of Epidemiology. Tizzy.
Thank you. It's a pleasure to be here and hear about all this variety of research. It's really exciting. So I investigate factors related to infertility, which affects about 15% of couples in developed countries. And my colleagues and I have, since around 2007, we've enrolled around 16,000 women and 2,000 of their male partners in studies in Denmark and the United States and Canada to identify factors that could help couples become pregnant when they choose to and hopefully avoid the stress and expense of going through infertility treatments. So one possible factor we've looked at is former use of oral contraceptives. And recently, with the help of SPH pilot funding, we've examined whether past use of oral contraceptives affects a biomarker of fertility called anti-Mullerian hormone, or AMH. So AMH is a measure of ovarian reserve, or how many eggs are still remaining in the ovaries, and it declines as women age, and it's no longer detectable once women go through menopause. So clinically, AMH is used to test women for when they're being treated for infertility to help predict their chances of conceiving. So oral contraceptives are the most commonly used form of contraception in developed countries. Many women start on OCs in adolescence and they stay on them until they're ready to start a family, which can be, many, many years later. So it's important to know if former use of OCs could have any effect on future fertility. And we and others have found a short-term reduction in fertility in women coming off the pill when they want to try to start to conceive, but that seems to return to normal after about 3 menstrual cycles. We also found evidence in our study that using OCs for longer periods of time might actually slightly improve future fertility, as shown in this graph where we see about a 15% increase in fertility rates with longer use of OCs. So in this SPH-funded pilot study, we collected blood from 165 women, and my colleague Lauren Wise actually drove all the blood samples down to a lab in Rhode Island to measure levels of AMH in a specialized lab that does that. And we looked at whether recent use, long-term use, and age when women first started using OCs were associated with AMH levels. We found that AMH was lower in women who were older, as expected, in heavier women, and in women who smoked. But AMH levels were actually a bit higher in women who had used OCs for at least 2 years in the past, which agrees with the findings I showed on the previous slide. Women who had recently stopped using OCs had slightly lower AMH levels, but the age at which women first had started using OCs didn't seem to have any effect. So I think our findings are good news for women who use OCs and are wondering about how that might affect their future fertility. The reduced fertility that we see after women stop using contraceptives seems to be very brief and only last about 3 menstrual cycles. But it also seems as though longer use of OCs might actually protect ovarian reserve, perhaps because women stop ovulating when they're on the pill. So next, our plans are to evaluate other contraceptives, such as the increasingly popular hormonal IUDs, to see if they affect ovarian reserve. And finally, I just want to say how grateful we are to have the pilot funding. We couldn't have done this study without it. And I'd like to thank my colleagues, in particular Dr. Lauren Wise, who's principal investigator of our North American study, the PRESTO study, and also our doctoral student, Katie McInerney, for her help with the data analyses. Thank you.
Thank you, Tizzy. For those of you who are with us who are not directly from the public health community, we are, I'm often asked the question, so what's public health about, right? So public health ultimately is about disease, yes, but also about the conditions that cause disease. And you've actually heard about a lot of that today. Just in our research, you've heard about, just my summary, number 1, from fish and rodents to humans, number 2, from smoking to homelessness, from pregnancy and birth to old age, from health policy to HR inhibitors and AMH, and then from South Africa to Nicaragua to the United States. And I really think that that's a smattering that represents very well the research that happens at this school. So please, first of all, join me in saying thank you to everybody who's just presented right now. But our effort at the school really rests, as I said at the beginning, on the sort of think, teach, do Aristotelian ideas. So we also support efforts on the teach part and efforts on the do part. And although we focused mostly on the think today, in no small part because a lot of this is funded by our pilot program, which is funded through generous help that we receive from many of you who are actually in the room. We also want to highlight a little bit some of the teach work and some of the do work. So we have 2 more presentations, and we're very lucky to have with us today Alexis Gitungano, who is going to talk about a student story. Alexis.
Greetings, and thank you for allowing me to share my story. I was born in Burundi, Central East Africa, a small country as the same size as Massachusetts. Burundi is the first or second poorest country in the world and has experienced civil wars and political violence to this day. Who would have thought that I would be standing up here in a time like this? My dad didn't finish the 1st grade. My mom didn't finish the 4th grade. During the Civil War in 1993, I lost my brother and other family members. My family and I fled to Democratic Republic of Congo, where we were targeted to be killed a couple times. In 1994, 1 year living in DRC, my mom lost the whole family in the genocide of Rwanda. As a young boy, I had many questions and no answers. Why God has this happened to us? But now I use my story as an instrument to fight for my right, defend for the need, and encourage others. There was a time we suffered from anemia, malaria in Congo. My mom could not afford medical care. She had to mix yogurt, Coke, and tomato paste and told us to drink so that we can gain blood back. I cannot explain this to you if you're a doctor here, but it worked out well. That's why my passion is to be a public health agent who reach out to underserved and those at risk. When I was in college, I helped the first burn survivor, Freddie. I traveled with him to Kenya for 3 years for his plastic surgeries. I was introduced again to another boy that I'm taking care of now. Leo was also burned by cooking fire at the age of 2 years in his village. I brought him to Shriners Hospital in Boston for his treatment. Today, through the generosity of so many, I'm here at BU. People ask me all the time, Alex, how did you get into BU? I don't know. Coming from another country with a total different system of education, French education, and there were a lot of requirement, questions, and uncertainties. How are you going to pay for it? Leah and I, we live by generosity of people, but I was not discouraged by that. When I started school, there were a lot to adjust to and learn, commuting 4 or 5 hours every day, going to school, taking care of Leah and his medical care. It was a lot. Through this scholarship program, my lifelong dream of being a public health professional is moving forward. Thanks to generosity education scholarship like yours, I'm thankful to God for this, and I would like to thank the BU School of Public Health Leadership, Dean Sandra Galea, Jonathan Cothi, and Professor Wayne Lamotte, and staff and my classmates. Thank you all. I would like to end by this. The sure way of living a purposeful life is giving while you are living. There's still hope even when a tree is cut down to sprout again. We are all called to be feet washers. Thank you. God bless you.
Thank you, Alexis. Next up is Dean Harold Cox, Associate Dean of Public Health Practice and Director of our Activist Lab. Harold.
I love being last. That's great. I'm Harold Cox. I'm the director of the Activist Lab. The Activist Lab is a vehicle to help engage our community in real-world activism. One of the projects of the Activist Lab is a project that we call Life on Albany. And this picture is a picture of Joseph. Joseph is one person who lives, hangs out, is part of the Albany Street community. Albany Street is the street just directly in front of our school. On this street are many individuals who deal with the issues of homelessness, with drug issues, with mental health concerns. And our community of faculty, staff, and students walk among these individuals every day, going to many of the different buildings in the area. And we have a number of different responses that people have. One response is, well, we should do everything we can for this population. Another response we have is, well, they don't bother me, I'm not going to bother them. Another response we get is, I wish they weren't there. I wish they would go away. And it becomes very important for us to find ways of helping to engage our community with the community that's on the street. So one of the things that we started was something called the Water Squad. The Water Squad is an opportunity for us to go out every day between June and the end of September and pass out water to the people on the street. It literally takes about 20 to 30 minutes to pass out 100 bottles of water. Now, why do we do this? We do this because we're interested in building a healthy community. We do it because we want to teach our students about how to understand the population, about how to understand the services that individuals need, as well as to understand about the importance of advocacy. Because each one of us has an Albany Street. It may be similar to the one that's near our school. It may be very different. But it's very important for us to bring our students who have an understanding of who's the population, what are the services, as well as how do you advocate on behalf of those individuals. We want our students to be able to make a difference in their community. So today I'm very grateful for the Activist Lab, and I'm particularly grateful to be able to have the dollars that allowed us to learn about and to engage with the people on Albany Street.
So I would like to ask you all to remember, when's the last time you were at an event with 20 speakers which actually ended on time? I think that's really a testament to the people who organized this, as well as to the speakers. Please join me in saying thank you to everybody one more time. And we have a reception right here at the Killichan Center. Please join us outside. The speakers will be around for conversations. Thank you, everybody who supports the school, and thank you, everybody, for being part of this magnificent community.